Guys, I think we are live. Okie dokie, lovely. Guys, today on the live session today, do let me know you can see us and hear us. I think we've actually forgotten about Instagram. Where are you guys on Instagram? Where are you guys on Instagram? You need to be live as well. Lovely. So guys, I'm going to kick things off in a second. I wanted to start off today's live session because I'd seen a comment on the YouTube channel about, you know, the contradicting guidance, the contradicting advice, the contradicting comments around lower back issues or lower back pain. And I wanted to just address that, hopefully in a way that's going to help a lot of you guys understand things, because it is really, really frustrating when you're struggling with a lower back issue and you go to see one guy and he tells you one thing, you go to see another lady and they tell you something different, and you feel like things are a little bit disjointed, to say the least. And actually, if we take a step back, we can start to see that maybe things aren't necessarily so disjointed, and you don't need to feel so disheartened about the confusing or conflicting information around back pain and sciatica. So you can feel a little bit more confident about how you're moving forwards. And I'll use the example here first of the case of the spondylolisthesis, because this commonly happens with the spondylolisthesis. And the patient will go and they've got an injury, and what a spondylolisthesis in the lower back is where you've got one vertebra. Now most commonly it's going to be L5S1 or L45, and one vertebra slides forwards on the other. And you will go to one clinician and they will say, hey, you know, look, you've got a spondylolisthesis at L45. And then you might go to another one and they say, actually, do you know what? Look at this bit here. The facet joint is really worn here. We've got some facet joint hypertrophy. And someone else might say, oh, well, we've got some ligamentum flavum hypertrophy. And someone else might say, actually, this disc is a little bit worn. And before we know it, we think that in this particular scenario anyway, that they are talking about different things. One practitioner might focus on the disc component of things, and another practitioner might talk about the facet joint inflammation or hypertrophy that we have there. And understanding that so often it is the case that these things are really all the same. And what I mean by that is, if you have an injury to the disc in your spine, if we look at how the spine moves, if you have strained the disc, these are not different joints. Like, for example, I could injure my right elbow and my left knee is not going to move, right? It's not going to be involved unless I fell down on my right elbow and my right knee, in which case both things could potentially be involved in that same scenario. But if I bend forwards, for example, I'm bending over to pick up something off the floor one morning and my back goes, I've strained the disc here, right, where my little finger is. But I've also, for that segment to become strained, I've also strained the facet joint capsule. That's going to create some reaction. I've strained the ligamentum flavum quickly, that's in between here. I've strained the interspinous and supraspinous ligaments on the back here. I have a segmental injury. Now, if I keep on doing that recurrently over a period of time, I might well start to find that I can aggravate individual parts of that structure on a moment-to-moment basis, because the segment now becomes unstable. But make no mistake, I can't move in one direction or another without injuring or irritating or involving another section of the lower back once we have that injury. When we have that injury, it's going to invariably involve many different tissues within that lower back, because quite honestly, none of me, I can't, you guys can't, you can't move the disc only. You can't strain the disc only, generally speaking, without other tissues being involved in some way, shape or form. That's the great thing about the body. The body is actually remarkably robust. The lower back is remarkably strong in that we've got supporting layers. The back fibers of the disc, these parts where you often get that bulging or herniation going backwards, well, those are reinforced by things like the ligamentum flavum, things like the interspinous ligaments. And so when we have these injuries, often we're trying to get the answer of, I need this, I want you to tell me it's this little bit here, or this little bit on the right, or that little bit on the left. For example, we've got here a comment, what is the possible cause of a herniated disc with a radiculopathy? Right? The radiculopathy is the comment that we've got an irritation of the nerve, and then that's obviously going down the leg, or it may be going, you know, all the way down to the big toe in certain cases, depending on the exact level of the spine. Obviously, we can get these in the neck as well. But the possible cause of the herniation, well, fundamentally, we can assume by virtue of the fact that the nerves are on the back part of this vertebral unit, we can assume that the disc is herniated backwards. That's the first thing. Often to one side or the other, so that it hits the little nerves as they exit the spine. And so we've got those symptoms. Now, it might be the case, in Marja's case, who's commented here, It might be that the disc is not actually hitting that nerve. It's not actually compressing that nerve against the wall. It might be that it's just gently contacting that nerve, or it might be that it's just the inflammation building up, irritating that nerve. But the cause will be very clear, right? She has gone forwards and often slightly with a little bit of a twist to one side or the other. Why is that relevant? Because before it was a herniated disc, or much before it was a herniated disc, it was probably a healthy disc, right? Or we can assume that it was a healthy disc at some point soon, or in the distant past, maybe in the recent past. And so the healthy disc doesn't often always go to this point here. And certainly you have to understand, guys, these are strong structures in the body. They are built to load bear. And we can see demonstrations of the strength of these things over time in certain athletes when you can really build these things up to be very, very strong. So if Marge's instance, where she had the herniated disc with the radiculopathy, was caused by bending over to put her socks on, that's not the kind of force that will damage a healthy disc. That's the kind of force that will just add a little extra bit. The phrase, the straw that broke the camel's back, is so often relevant here. She was probably in the scenario where she had this kind of thing going on already, right? Where the disc had already broken through a couple of these layers of annulus fibrosis. For a reminder here, guys, the annulus fibrosis has lots of layers. You can see it on the model here. Lots of layers of ligament, and all of those hold that nucleus in the middle. That's the bit here, the bit that's in red on these ones here. And so what has probably happened, for example, in Marge's case, is as she's gone forwards, there's a vulnerability. She's gone a little bit to the side. So now, as she's squashing down on the front part of the disc to go and do something, and then she leans a little bit to the side, she focuses all the strain through that weak point, and that's what causes things to get a little bit worse. Now, it may not even be a full-blown herniation. It may just have torn through one more layer of the annulus fibrosis, right? Just one more layer, and that's created an inflammatory reaction. Now she says, I can't bend forwards and relieve the pain when extending backwards. If we've got a lot of inflammation there, we're not going to be doing one thing to alleviate the pain often. The best thing we can often do is simply lying down, taking load off the spine, although the exact positioning of that can sometimes be a problem after extended durations as well. And we've asked one follow-up question here, and then I'll come back to this in a second. It says, is it a nerve problem or the disc itself? It is a disc injury. You do not get primary nerve problems in the lower back fundamentally. Now, I did see someone commenting about something else, which was a little bit separate, but if you've got a mechanical lower back issue, you don't have a nerve problem. You have a lower back issue that's creating inflammation that's irritating the nerves. The nerves do not get irritated for no apparent reason, and it's very, very difficult for the nerves to be interfaced with. So unless we are suggesting, and I'm always a bit reluctant about saying this, but I suppose it needs to be said, there are a small handful, very, very small handful, very, very small handful of insidious cases of lower back pain, i.e. non-mechanical insidious cases of lower back pain, where we have some kind of tumor or something like that, something nasty in the lower back. Okay, that would be a scenario where you could suggest that maybe there's some irritation of the nerve and that might be a primary issue, right? But that is so incredibly rare, so incredibly rare. We're not getting those sorts of things in ordinary patients, certainly not the example that we've described just here. And so when you have lower back pain with nerve issues, although people talk a lot about the nerve pain, you've got nerve pain. No, anyone with, you injure your knee and you have pain, that's nerve pain. You bang your big toe. If I stub my big toe by accidentally kicking this bench here on the metal, that's nerve pain, by the way, right? Because all pain is mediated through the nerves, right? A signal goes up to your brain processes that nociceptive signal as pain. So all pain is nerve pain, but it's not a nerve problem. It's a back injury, a mechanical injury, right? That it happens to be in a location where inflammation building up around there can then irritate the nerve. A very, very important thing to understand. So if you start going to try and treat the nerve pain, you're going to do things that are often violating the actual underlying problem. What I mean by that is, you might say, oh, well, the nerve is trapped. So what we'll do is we do some sciatic nerve flossing, where we're going to get into this position and do this kind of stuff, right? Well, in the pursuit of trying to just free the nerve, whatever that even means, you're going to make the underlying back injury worse because you're absolutely hammering through that disc, and it's not helpful. Understanding the layer of, the layer of importance, if you will, is really, really important. Your nerve symptoms, your sciatic nerve irritation, your sciatica going down the leg, those are symptoms of the injury that is in the lower back, at the lumbar spine. There's only a couple of things that can go wrong here, guys. There are really only a couple of things that can go wrong, right? If we take the knee, for example, maybe there's a few more in that scenario, but it's the cartilage, which would include the hyaline cartilage of the tibia, so the fibula, the meniscus, the retropatellar cartilage, that's the cartilage, right? It could be the ligaments, the lateral collateral ligaments. It could be the cruciate ligaments inside the knee, right? That's what going on. It could be the tendons. Okay, maybe it could be a hamstring tendon. It could be the IT band coming down the side here, tendinous type structure, we could say, or ligamentous tendinous type structure, right? There's only so many things that can actually go wrong in a joint. And in the lower back, we've got the disc, we've got the facet joints, and we've got the ligaments that run in between. Those are the things that you injure, right? And if we think of the example of the spondylolisthesis, all of those factors, all of those tissues are going to be involved in that injury. So it's relatively simple. There's only a handful of things that can go wrong. And then we need to support the healing, the healing of the injury in that case, and understand that injuries to any of those tissues can create an inflammatory reaction in that area, or in the case of the severe disc bulge, they can actually hit and contact and compress the nerve to create those nerve symptoms as well. So often people will get the scenario where they have a disc bulge and they get the MRI back and the doctor says, or the surgeon says, oh, well, you know, this can't explain your sciatica because it's not touching the nerve. It's like, yes, it can. Yes, it can. It's at the right level. You've got symptoms in the right place. And when you aggravate that particular disc, your symptoms come up. Let's assume it is, right? And the funny thing about that is when you assume it is and you act as if it is, all of a sudden things resolve. It's kind of retrospectively, you can see what you thought made sense. Just looking through, because I'm aware that a lot of you guys have posted some comments in here, so I'll try and come back through some of these. Janissa has said, I have a herniated disc for almost a month now. When I lay down, there's no pain at all, but when I stand up for an hour, it hurts. Great that you can stand up for an hour, because some people can't stand up for 5 minutes, you know? We've got to start with the rehab. If you're not doing the rehabilitation work, these things will not get better on their own, with lower back specifically. And the reason I say that is it will be trying to heal every single day. It will be trying to heal every single day. However, with lower back issues specifically, you don't have a second one that you can lean on. You don't have a spare spine that you can lean on, or you can put yours off to the side like we can with a knee or with an elbow, etc. And so you're doing things every single day that are aggravating and interfering with that healing and recovery process, which is why people say things like, incorrectly so by the way, the annulus, fibrosus, the discs don't heal. Yes, they do. You can, anyone that's gone through the program or patient that's come through the program with a disc injury, their discs have healed. Right? Their discs have strengthened. They haven't somehow managed to magic their way around the disc. It's gone through a healing process. However, discs in the lumbar spine specifically, more so I would argue than the neck, are in this precarious position where they are unfortunately under an unnecessary or irritating strain on a daily basis, and it's very difficult to eliminate that down to zero to give them the respite they need. That's not to say they can't get better. They can, they will, but it often leads to a more up and down route of recovery with relapses along the way rather than a smooth recovery. It happens all the time. But you have to be part of that solution. We cannot be there going, well, I'll just leave it and see what happens. It should have healed by now. Yes, it should have, but if you're maintaining the dysfunction, if you're preventing it from going through a healing process, it's going to struggle to actually go through that healing process effectively without constantly being set back. Looking for some of the other comments here. I don't have a herniated disc, but back pain with tingling in the feet. It's been 4 months now. What do I do? We should be doing rehabilitation work. Now, for those of you that don't know, the rehab work, it's simple spine stability exercises. You have an injury here. What have we injured? We've injured the structures that maintain the integrity of that joint, the stability of that joint, the things that allow it to function correctly and move in the correct sort of way, you know, bending, right? And so while we've got a compromise, those joints don't move quite as well as they otherwise should. And this is another challenge with the spine compared to, say, the knee joint. You can't control L5S1 or L4-5. You can't control L3-4. You can only control and stabilize the area between the rib cage and the pelvis. And a lot of people can't, so they need to learn how to do that. And that's not particularly complex. It's just learning to engage the core correctly. But that needs to be done to support and protect the injured structures whilst they're going through a healing process. So if it's been 4 months and we haven't been doing this kind of work, and we haven't been mastering it, then we haven't built the baseline level of skill to protect that L4-5 or L5S1 herniated or bulged or injured disc in the lower back from constantly being aggravated on a moment-to-moment basis. Leah, I might come back to that question about military neck a little bit later. Marge said, I'm doing therapy now. I'm wondering, will it get better? It depends what therapy you're doing, guys. You know, people often ask, well, I've tried physiotherapy, you know, so exercises don't work. It's like basically everyone of the thousands and thousands of patients and members that have come through the program have done physical therapy or exercises before they've joined the program, right? And guess what we're doing in the program? exercises, right? But how you do them matters. How you do them really, really matters. Little things matter. For example, I was talking with one of the guys in the members area today about doing his hip hinges. He's a little bit further on in the program, a little bit stronger, but he was doing something very interesting. And I'll demonstrate it for you guys, because I can't stress enough how much this stuff kind of does matter when we are doing our rehabilitation work. Because you think it's just while you're doing the exercises, but it's not just while you're doing the exercises. It's before, during, and after you do the exercises, because how you do anything is often how you do everything. So you want to try and develop good habits, especially when you're in the recovery process, because the way you're doing anything in your rehab, it's only going to be worse in the real world, right? And so what he was doing was picking the bar up off the rack for the hip hinge, and we had a good bit of weight on the hip hinge, and that might be in the way. Oh, yes, great. It's not quite in the way, right? And he was doing the hip hinge, and he was making such a simple little mistake, but it makes a difference, right? And what he was doing is he was kind of coming like this and picking it up off back and then getting into the movement. He wasn't properly engaging himself before he starts the exercise. Instead of getting over the bar in the actual hip hinge position, getting everything braced, getting everything engaged, grabbing hold of the bar, and then doing an actual hip hinge to come up and then taking a step back. We're almost kind of leaning like this and just pushing backwards, right? These little things, they really do make the world of difference when you're doing your exercises. It's super important that you get these things right, and the details matter. Simple things like a squat. You can take people that come, for example, into the clinic and they say, hey man, I can't get out of the chair without terrible back pain. It really, really hurts me. And then you literally show them, instead of getting out of the chair like this every time, right? Oh gosh, it hurts when I straighten up. You teach them that they need to first get themselves upright, get the feet underneath you, right? Feet underneath. Get over the edge of the chair a little bit more, and then think about coming straight up, like so. And all of a sudden, in about 30 seconds, you have eliminated the pain that the person experiences when they stand up. Now, have you healed their back in that instance? No. But that you've taught them a vital skill of how they should be moving their body, controlling their spine, not bending it all over the place anytime you go from A to B. And this kind of stuff makes a world of difference. It should be refined in our exercises, our rehabilitation work, and then it should be dragged around with us when we're doing daily living. But too often you'll be doing some like silly clamshells on the floor as part of your rehab, or doing like a pigeon pose, and it's like, what use is that? It's a very limited utility. Just going over to Lewis, who said, is it normal to feel slight pain or flare-up after a PB on an RDL? For example, the hamstrings still feel super painful today in a muscular way, but feel stiff. Yes, yes, yes. I was just playing around with hip hinges before, earlier today, before the live session, about an hour ago or so, and was pushing it a little bit on those. And like the hamstrings, the glutes, even like immediately afterwards, they're feeling a little bit tender. One of the things that are really important for you guys when you get later on in the program and are building your strength and resilience in this lower back, right? You have to utilize load with correct form, as I just mentioned, in order to build the strength and stability back up in these discs. And you can do this, like the proof is there, right? The proof is there. We can build strength and resilience, and we've seen it time and time again. It's easily demonstrable, right? However, the one thing that you've got to watch out for is that when you do push yourself, like Lewis has done here, and you're getting a little bit of that DOMS, that delayed onset muscle soreness, the stiffness in the hamstrings, the stiffness in the glutes, those things can be a little bit of an irritant in the subsequent 24 or 48 hours, especially if you don't manage them well. So using the massage guns, using your lower body stretching to try and expedite the time frame in which your hips go from being stiff post-workout, perfectly normal, acceptable, to back nice and supple again, ready to improve your range of motion further, is something you want to try and compress as much as possible, right? Because you will feel sore. Like sometimes if you start to get to a good point in your workouts and you're actually challenging your leg muscles on those hip hinges, etc., the RDLs, right? Or even the squats, and you're kind of feeling a little bit stiff afterwards. Those muscles are tight. They got full of lactic acid, for example. They're not moving as well, which means that for the next 24 to 40 hours, you need to be a little bit more careful, because when you're going down to do stuff, your hips don't have the range of motion. You can feel the stiffness in the hips. Perfectly normal, but you need to negotiate that time period with a little bit of care so that the natural normal stiffness in your leg muscles as a result, and the back as well, because that's going to be a bit stiff, but that's not as much of a problem in this particular scenario, right? You need to be wary of that time frame to make sure that you go through it and come out the other side without any trouble. Often when people aren't aware of this, what they find is that they start getting some progress, they start pushing themselves on the rehab, and they're fine in the workouts, but then they start to notice insidiously, without any particular reason, things have started to creep back. They've got a bit of irritation in the lower back, and it's because the hips, the stiffness in the hips as a normal part of training hasn't been managed as well as they otherwise could be. So we have to make sure we take care of that particular part. Lewis says, when squatting or doing hip hinges, I still notice a little bit of a hip imbalance, shift to one side. Even though I'm making solid progress overall, will this asymmetry essentially return to normal? Yes, but I would also add the caveat, if there was almost certainly some kind of asymmetry beforehand, you just hadn't noticed it as much. Because most of us as human beings have a dominant left, a dominant right, one or the other, right? Our quads are a little bit stronger on the right leg because we used to play football or rugby or whatever the case may be, or that's our dominant leg, and the hip muscles are a little bit stronger on the left side. Same thing with our arms, right? We are asymmetrical beings that operate in an asymmetrical world, right? And we're using these symmetrical skills, and it's great that you're being aware of these things now, and you will find that you can really refine this even more with exercises like the single leg hip hinge, the step up, and the Bulgarian split squat. They are fantastic ones to help rectify this, but for the time being, especially while we are below, I would argue really the 75, certainly below 50% of your body weight on the squats and hip hinges, I would be worrying primarily about getting those numbers up in terms of load tolerance in the symmetry environment. Gradually you'll find things get better and better, but you're always going to find there is going to be, I would suggest, unless we are the kind of individual that has many, many hours every day free, and we don't have a family, we don't have kids to look after, we don't have a job, right? You know, unless we've got all that extra time, we might find that the activities of daily living just lead us to have a little bit of asymmetry one side to the other. For example, you know, we've got the girls, picking them up, right? Evelina, 3 years old, Celestia, just over 1, right? You're picking them up, you're generally holding them on the same side. I know Lara is, and I know I am, right? And because you need the other free hand to do stuff. So you're going to regularly be standing a little bit crooked. People don't realize that these things are often there long before you've injured your back. Yeah, they maybe play a role, but you're never going to make things perfectly symmetrical. You're a human being. You habitually sit with one leg over the other. Is that going to cause back pain? No. But will it become a little bit more noticeable, the asymmetry, if you have a back injury? Will those kind of things be a little bit more of a challenge to overcome? Sure. But people make the mistake of trying to deal with the asymmetries while they're weak. Well, they can't even squat 10, 15, 20, 30, 40 kilos. Deal with them a little bit more later on once we've got a baseline level of competence. Selena has said, I'm interested in the fibrosis recovery. In your opinion, is Pilates a good shout? Not really. Pilates is a hobby. Golf is a hobby, right? And I'll just use to contrast. Some of you guys will have heard me say this before. If you've injured your back, you don't take up golf any more than you take up Pilates. Why is that? Well, Pilates, well, it's off weight bearing. You do the dead bug. The dead bug is a Pilates exercise. Yes, it is. And we recommend the dead bug. It's a great exercise if you do it correctly, of course. So is walking. Walking is helpful. Walking is a relief strategy. It's not rehab, it's a relief strategy, right? It helps you get a little bit of movement through the lumbar spine in a low amplitude way to help get rid of excess inflammation and manage the inflammatory buildup in this section of the lower back within aggravation-free limits. Is very important. You don't take up golf because it has walking in it any more than you take up Pilates when you have a back injury because it has the dead bug in it. Those are hobbies. Leave them as hobbies. Now, can you do a specific selection of activities that might be seen in a Pilates studio? Sure. Right? But don't take up hobbies when you've got a back injury. Do a program of rehabilitation and then get back into your hobbies afterwards. And be careful of things like Pilates for back pain. It's like, is it Pilates for back pain or is that just marketing? Right? They've just put for back pain after the Pilates sign, as opposed to actually really having like a thorough think through of the principles of a back injury and the principles and attributes of a lower back. And if that Pilates does not include an element of load-bearing component to it, such as a squat or hip hinge, then it cannot possibly be a complete back rehabilitation program. Because in order to completely rehabilitate the lower back, there has to be a component of progressive load bearing in it. So if your programs, whether it's Pilates or just your standard physio, if it doesn't include loading this thing progressively over time in a greater level, then it's not a complete rehabilitation program because it's missing a fundamental, the fundamental thing that the spine does and the fundamental thing that the annulus fibrosus specifically has failed in doing because it's injured. I'm just looking at some other comments here. I'm going to see the physio to help me with building core strength and stability. I've just had a discectomy. What would you say is very important to tell a physio? The best thing I could do, I would suggest to you, Selena, is have a look at the program. Have a look at the materials that we've got on the channel here. It depends on whether the physio is a good physio or not. You know, if it's a good physio, you don't, they need to know what, it's what you tell them obviously is the standard case history, but it's more in a case of what you can and can't do that informs what they're going to do going forwards. Evidently, you've managed to get to the physio appointment. So you've got in the car, you've got out of the car, you got dressed in the morning, right? You probably had breakfast. You've done a bunch of things in order to even get to the physio appointment. So we should be doing stuff that acknowledges that, such as the squats, the hip hinges, and we should be working through those. And those are a test. Your ability to perform a squat without rounding your lower back, right, to a reasonable depth is a test, an exercise, and a reevaluation tool itself. Super simple. And it's relevant to everybody at all stages because Selena will have already done day 6 post-operation after a discectomy in the lower back. She's probably already done squats more than 10 times. And that's really important to bear in mind. Just looking through some of the other comments and then I'll come back over. We've got YouTube. Can you explain what happens to the muscles when you have flare-ups on a monthly basis? Atrophy, nerve damage. So the muscles don't have anything to do with really the nerve damage, I would say, or don't cause the nerve damage. When you have a back injury that is poorly managed, what often happens is you end up doing less and less and less, and that leads to muscle atrophy. Muscles are the only thing that is protecting and supporting this particular area. Muscles being used in a coordinated manner, right? Because you can have muscles, but if you're bending your back all over the shop, you're not using them in a smart way. So that's why technique is so important first, to create the ability to stabilize and protect this spine. But if you're having recurrent flare-ups, this is something we discussed in the podcast on herniated discs. For those of you interested, either send us a DM or something like that, because we did a very deep dive, a 40-minute long podcast episode with about a 4,000 to 5,000 word article going into the details here of the cost of not doing your rehabilitation for a herniated disc correctly and the important role of strengthening here. And we explain it and lay it out very clearly. So send us a DM on Instagram or TikTok if you're watching and interested in that particular article. It's on the website, but we'll just send you the direct link. But if you're constantly having recurrent flare-ups, that means you're dealing with it badly, which means you're getting weaker, which means your ability to protect this area is getting less, which means the flare-ups are going to get more frequent, often do, right? And then you then do less, and so it becomes a vicious loop. Many of you guys watching who struggled with herniated discs for anything longer than like 5 or 6 months will be able to attest to this fact that things just seem to be going down, down, down. And if you're not doing anything to build back up that is effective, strength-based rehabilitation, starting with technique, of course, then yes, you're going to get a process of atrophy, muscle atrophy taking place. The good news is you can also undergo muscle hypertrophy, which means we can build things back up. That is an essential part of the process. Are you going to constantly be irritating that nerve if you're constantly having flare-ups? Yes. But the primary issue is the fact that you keep on injuring this poor little guy down here in the lower back. And that's what we need to stop doing efficiently. Fisher said, are there also nerves in the glutes that are affected by it as well? I think sometimes we get confused about this concept of nerve pain. If you're going to irritate the nerve, the primary area that you're going to actually irritate a nerve is going to be in the spinal canal here. These are the main areas where nerves can get caught. Another great area where you can irritate a nerve is if you bang your elbow right here on the edge of the table, you're going to get radiating symptoms down into your hands, the funny bone, so to speak. You're just banging all the nerve. But other than that, people will often say, oh, it feels like a nervy pain in my buttock, or it feels like a nervy pain in my hamstring. A lot of that might well be a degree of muscle spasm, muscle tension in those particular areas as a result of the irritation of the nerve here in the lower back. It's not that it's a nerve problem per se, although the nerves being irritated is a problem for you, symptomatically wise. What else have we got here? Looking through the comments on TikTok. Let me just scroll back a little bit. I've lost 3 inches in height and worry about my posture, how to correct it. Carol, if that's 3 inches in height recently, and it's just postural and you can straighten up, then do that. If it's because you sneezed or anything like that, or we have any history of osteoporosis, you need to check that Is it normal for someone aggravating when activating the core in the early stages? Yes. A lot of people will strain, they will tuck their pelvis, they won't quite be doing it correctly. They'll be doing a pelvic tilt. Those things are incorrect. For some people, if you're doing the exercises on the floor, this is the stuff that often people don't get taught, right? With lower back pain. You're there like, oh gosh, it hurts when I engage my core. It's like, no, it hurts when you get on the floor. If I just told you to get on the floor and get back up again, it would have hurt your back. Because you're rounding and twisting and bending, because you've got really limited mobility, because you've got a bad back, because you've got sciatica. So you can't really move like I just did then. You're there like, and then by the time you're down there, you've already irritated your back. It's nothing to do with engaging the core. You've irritated your back just to get down there. That's been the problem, right? That's been the problem. You've irritated your back just to get down onto the floor. And so make sure you're not making that mistake. And that's one of the reasons why we say for you guys, when you're doing your core engagement exercise, you should do them on the bed to start with, especially if you're particularly vulnerable. Because you don't have the competence to get on the floor, right? You don't have the competence to get on the floor. And going back to the physio appointments, right? That's one of the reasons why patients wanting to come to the clinic nowadays, we say, no, you can't come to the clinic unless you're doing the program. And there's no point you coming to the clinic until you've started and made some progress with the program. Because how can I honestly sit there and say it's worthwhile you coming into the clinic, getting in your car, maybe getting dressed in non-comfortable clothes, right? Because you're at home, you've got a dressing gown on because you're really struggling, right? How can I realistically say it's worthwhile you going through all of this, getting dressed, getting out the car, getting in the car, sitting in the car for a number of maybe hours, okay? Because some people come from quite far, right? And then coming in, sitting in the waiting room, and then going through treatment, and then doing all of that in reverse? Is that really worthwhile when you haven't even started making some baseline level of improvement in your rehabilitation, in your ability to control yourself, right? Isn't it better, far better, that I say you start doing some of this stuff at home? Start educating yourself. That's a zero strain activity, right? Do it in whatever comfortable position you can that's not straining the lower back. Start practicing some of the simple rudimentary movements. The squat, for example, right? The hip hinge. Get an appreciation for your level of control on those movements. So then when you do come here, on the day you come here, you're taking it carefully. You've got a little bit more guidance. You don't walk in, so many times, over the years, the amount of times it's happened, people walk in, oh, hey, nice to meet you. I'll just put my bag down there and then go and sit in the chair. It's like, oh, goodness me, look at how natural that is. Oh, gosh, that hurt. Or sometimes it's like, oh, it didn't hurt. Oh, okay, so how many times a day are we doing that movement? Right? And wondering why we're struggling to get better. And pay attention to these things when you see patients, or you should be, right? So that's something to think about as well from a point of view of treatments, sessions. Just going back over to YouTube, if you manage to increase, limitless, if you manage to increase your weight to body weight on the squat and RDL, but suffer from pain or nerve symptoms, assume to matter if the weight, or other nerve symptoms, assume that no matter if the weight is your body, the nerve damage will be there regardless for longer. I'm going to kind of make some assumptions in this particular scenario, but generally speaking, I cannot think of the last time I had an individual who was at their body weight squatting and hip hinging without aggravation, who also had appropriate levels of hip mobility on those movements, very good levels, who still had symptoms. It doesn't happen. It's very, very rare. That's not saying it can't happen, right? Because there will be some athletes that have just injured themselves, et cetera, et cetera, et cetera. But it is almost unheard of that you will get someone that has built all the way up to their body weight for 10 reps on a squat or hip hinge without aggravation free, right? Not just pushing through, aggravation free. And they've got great levels of hip mobility, which might then need to be built at that point, that they still have those situations. But if we do have nerve damage and we get up to that level quite quickly, right? This is worth bearing in mind. If there's been nerve damage, it can take longer. Well, no, sorry, not it can. Nerves heal much more slowly than even the disc fibers. We talk about them healing very slowly. Ligaments heal in a matter of months. Your nerves are going to heal much slower than that. But if you have nerve damage, we are talking about a more or less constant level of awareness of that nerve damage. Now, the great example here, thinking from recent examples, is the individual that has a microdiscectomy, and maybe they bruise the nerve a little bit in the process of doing that, which sometimes happens, and they're left with a tingling in the big toe, right? The L5 nerve was hit. And they've noticed that after the surgery. But often what happens in that scenario is the sensation starts to settle down a little bit, but it's still there. And it's most there when they're not doing anything, when they're lying in bed. When their mind is occupied with other things, they notice it less. But it's still there if they pause for a moment and think, yep, I can still feel that toe. But then they get on with other things, blah, blah, blah. And then when they come back to lie in bed at night, oh, I still feel that big toe there. It feels a bit funny on the duvet, right? In that scenario, yes, the nerves do heal very, very slowly, but that's the kind of thing you're looking at. If we're talking about variations, variable sensations that happen one moment to the next, that's not quite the same. That more sounds like an example of a transient irritation, a temporary irritation. And one of the things that I haven't discussed as often, but I'm thinking about some chats that were going on in the group. You know, those of you guys that stand at work all day, that you're standing for extended durations, don't underestimate the fact that we can get a little bit of aggravation of the plantar fascia. So it might be that there's a bit of tingling on the feet from being stood up all day on the same spot for extended periods. Limit said, aggravation-free means not an issue post-session and the day after, right? I don't have constant awareness of the pain, just more discomfort, random tingling. Yes, the random tingling bit is like, no, that's not constant nerve, that's not nerve damage. Unless it's that scenario where I just mentioned, right? Where if you're busy doing stuff, you don't notice it, but if you just stop for a second, you notice, oh, there's a bit of tingling there. And if you stopped for a moment in the middle of being busy, you noticed, oh, there's a bit of tingling there. No matter what you do, if you always pause for a moment and you know, oh, that big toe is still a little bit tingly, then in that scenario, that would be the scenario where I'd say, yes, that sounds like there is a bit of residual nerve damage. And when you really pay attention to it, you can still notice it's not quite right there. It's not quite gone through that healing process. But when you're distracted with other things, you don't notice it as much. That would be the example. But aggravation-free, generally speaking, we have control over the session itself. I wouldn't say aggravation-free means it includes the post-session and includes the day after. Because there will be so many other things. How do you know it's a session and not so many of the other things? How do you know it's not a cumulative thing, right? For example, I use the case, you know, if I finish my heavy hip hinges or squats, and then I just go and sit down on the laptop for a bunch of hours, or just sit down and do a bunch of other things, or do some stuff that's not ideal for the lower back, or on the flip side of that, remember a couple of years back, I was doing the driveway, digging the driveway. If I finish my hard session and then go and dig the driveway, that's not a fair test to say, oh, was that the workout, or was that other things that could have been related to a more of a cumulative strain, rather than just the strain of the actual workout itself. So that's something to bear in mind. I'm just looking through some of the additional comments. Yeah, we've done the aggravation-free. Is I greater than my ability for aggravation-free session and post-session can become skewed. For example, the way I'm doing is super easy. That last comment, Limitless, I'm not too clear on that. Is it greater than my ability for aggravation-free sessions? One of the things to do after your sessions is the core relief work. Get on the towel, do towel decompression. Some nice massage gun work, bed decompression. Those are helpful things to do after you've had a good session in the gym. Just looking at some of these other comments over here. Nirav, just comment on that last one. Is I greater than my ability? I don't quite understand that particular comment. I'll come back to it. Taya has said, if you have a specific lower back that every day, every minute, every hour bothers you, help. I assume Taya's struggling with that. If it's bothering you every day, every minute, and we're in a pretty dire state of affairs, we have to have some degree of objectively valuing the level of discomfort that we're in, or make some attempt to progressively evaluate the level of pain that we're actually in this scenario, so we can give it some kind of baseline, if you will. It's always a 4 out of 10, or it always varies between a 3 and a 6 out of 10, right, on a daily basis. Great, that's really important to know. Then do the exercises, do the rehabilitation work. And if you do the rehabilitation work, make some progress there, but understand that you're still going to be a 3 to 6 out of 10 pain on a daily basis. And just carry on, Because you're already doing daily life and aggravating your back. You may as well do something that's constructive, that's progressive, because you're going to be aggravated at 3 to a 6 out of 10 anyway. So you may as well factor in that rehab work Make sure it doesn't make it go from a 6 to an 8, right? And if it does, then we can get in and dig into why that might have occurred. But you've just got to do it anyway. What have we got here? Can you talk about hypermobility? I think hypermobility, those of you guys that have that, EDS being one of the examples that commonly gets posted about, if you've got those conditions, you've got objective hypermobility, assuming you're not of the variant that you've got your shoulder joint dislocating out all the time, right? That we've got that proclivity to be hypermobile, but it's not to that degree that I just mentioned. Then I think it's a liability in the short term, because with a back injury, you have increased levels of instability. And so if we also have hypermobility on top of that, everything's wobbly. And so that's why it's even more important, the sort of stuff that we talk about, building back in stability, building back in control. Often the hypermobile individuals are the individuals that focus and gravitate towards, guess what? Doing more stretching. They gravitate to doing yoga. They gravitate to doing all that bendy stuff, right? Unfortunately, that is the case so often. And so they're often very much understrong. And so we need to build back up strength. I do think for the hypermobile individual, if you do things correctly and build back up strength, the degree of hypermobility that you have will often be an asset in the long term if you can do the work. Well, you can, but it's just a case of whether you do or not. If you can do the work to build up the appropriate levels of strength and stability by developing strong muscles around these joints to offset this congenital condition whereby the connective tissues have a little bit more play in them, I think you can do very, very well. You can do very, very well, but it's harder to get the ball rolling, especially if you're starting from a very low level of strength, because you are just so unstable all the time. Looking at what else have we got here. Is it possible to reset the nerves long term? L4-5 spondy with a disc herniation. So an L4-5 spondylolisthesis we're talking about for Joe the peasant. And it's not about resetting the nerves. It's about stabilizing the injury, stabilizing the injury. That's what you need to do. You need to stabilize the spine. If we have a spondylolisthesis, we've got this slippage forwards of the vertebra, maybe grade 1, grade 2 is the typical. We need to stabilize that area. We need to learn how to control and stabilize the neutral spine, and then build load-bearing capacity back into that section of the spine. It's not about the nerves, it's about the spine. The skeletal structure, the skeletal ligamentous muscular structure. That's what you need to focus on rebuilding. Taya said, they say it's finals to know what your opinion on the particular issue. Sorry, I don't follow that particular bit. Oh, they say it's spinal stenosis. Spinal stenosis is not a diagnosis. Spinal stenosis is an observation. So for example, going back to Joe the peasant has a grade 1, sorry, I misread that. He has a grade 1 spondylolisthesis with a pars defect, which pars defects are often going to be developmental, meaning you've had it your whole life. So we've got the grade 1 slippage going forwards. When you have a grade 1, grade 2, grade 3 spondylolisthesis, you have a degree of stenosis. When you have a disc bulge like this, you have a degree of stenosis. Stenosis does not tell you at all the whole picture. If we have a significantly dropped disc height like this, the two sides of the hole here have come together. You have stenosis, a degree of stenosis. Now, it might not be very severe. It might be very severe, but stenosis is not your injury. Stenosis is just a statement that two holes are smaller than one another, smaller than they otherwise should be, or a hole is smaller than it otherwise should be. We have stenosis that is caused by a disc bulge at L5-S1. Great. We know what the injury is and we know what the consequences are. It's completely occluding the space. There is no space. The nerve is constantly compressed. Okay, that's great. Does it change what we do from a rehabilitation point of view? Not really. It doesn't change what we're doing from a rehabilitation point of view. The stenosis is one of those diagnoses that it's not a diagnosis, it's just a description of something that's happened in that area, or an incomplete description, and stenosis must be used in context with the rest of the picture. You won't get it, you generally speak, I hope, you haven't got a report back that says you've got stenosis in your back. That might be what the person reading out the report to you, because sometimes it's not the doctor, sometimes it's not the specialist, has said. It might be what, I hope not, but it might be what the surgeon said, right? You've got stenosis. But they shouldn't be. It shouldn't be what they've said. If you read the report, you'll see comments of stenosis, but you'll see it in context of a wider description of what's going on in the lower back. What else have we got in here? This is a good point. Not sitting, striding away after the workout. I try to keep standing or moving. Keeping moving is good, but the other thing to bear in mind, if you are someone that stands up a lot at the desk, and you're standing all day, and then you do a workout, and then you stand all day afterwards, there is a balance to be struck, and it might be that that balance was okay in the earlier stages, but now we need to reevaluate that balance of standing during the day. Because actually, if you're standing all day, your legs are going to get stiff. And if your legs are going to get stiff, that's going to negatively affect your mobility when you do eventually relax. So something worth bearing in mind. Is my strength masking the aggravation post-session in the following day? No, no. The load is going through your spine, so I wouldn't say that your strength is masking the aggravation, because we've done specific things in the past where we've got very clear aggravation at a significant level. So if I could easily do 40, 50, 60 kilos in squats and do not have an issue during the session, but post or the next day, is that a concern? It really depends. It really depends. It really depends. What sometimes can be helpful is just having a 3, 4, 5 days of just doing no loading, no squats, no hip hinges. Just have 3, 4, 5 days of just doing care of self work, just doing core relief work. Don't go to the gym. Don't do any of that, right? Just for a couple of days, see what you notice, right? And then go back in. Now, 3, 4, 5 days is not enough to lose significant levels of strength, right? So just bear that in mind. But just as a one-off test, right? And that might give you a clearer representation, because you might notice that on those days off, you had pain on day 3 and you had some pain on day 1. Exactly the same sort of pain as you had when you did 40 and 50 or 60, for example. And therefore, what we're experiencing in this particular scenario is just the usual variation of where symptoms are at right now. Limit said I'm reclining as well during the day, which is during work as well, which is good. Feeding that one in. So like a deload, yeah, like a rest week. Just like a rest week. Just as a one-off. It's not something that you need to continually do, but it helps you reevaluate the lay of the land compared to when you rested before you started doing the rehab. So before you started in rehab and you weren't going to the gym, what were your levels of symptoms? And then you have this rest week, what are your levels of symptoms? Because for some people, you have to remember that the workout itself is a challenging experience. It's the hardest thing you're going to do every day when we get up to those sorts of levels, 40, 50, 60, 70, 80, 90 kilos. It is supposed to be the hardest thing you're doing every day. And for certain cases, as you get to that kind of level, there does need to be some kind of reaction, right? You can't just go to work out at the highest level of working out and just feel like, no, I didn't do anything, right? So I had a week off the other week, and I came back in, and I did stuff that wasn't my max weight, but my chest was sore, my triceps was sore afterwards, right, the next day, and for a few days actually. And so it's understandable to experience those things, even if we're not working at what we might think being the strongest level. But the question is, when did we last do 60 kilos on a squat or hip hinge in this particular context? Have a reflection on that, Nirav specifically. Obviously, for other people watching this, they might be like, where on earth are you going with this? But that kind of follows on from some of the chat in the group. But have an honest reflection, Nirav. Think, firstly, when was the last time we did something like 60 kilos on a squat or hip hinge for 10 reps? Something worth bearing in mind. But considering a deload week, maybe not this week if we've already started the week, but something to consider just as a tool to evaluate the lay of the land. Fisher said, what are your thoughts on seeing a chiropractor while doing the program? Perfectly good. If you are seeing a chiropractor whose beliefs and approach aligns with the program, aligns with the principles of a neutral spine, they're not there doing forced forward bending of your lumbar spine, and they understand their role, then I think that can be really helpful. The same for a physio, the same for an osteopath, the same for having acupuncture or going for a massage. Those things can all be helpful, providing the individual understands their role in the process, right? If the chiro is going to stand there straight-faced and say, I'm going to help heal your disc, and we're going to do something to heal your disc, I want a very good explanation as to how precisely that's going to be happening, right? I really want a good understanding of how that's going to be happening, because I'd question that. But if they're going to go and see you and you're going to be like, and the chiro says to you, hey, I'm going to help you out, and we're going to get a bit more motion through your thoracic spine, your hips are a little bit stiff, so we're going to help those. We're going to work on the neck a little bit as well. And that's going to get all these other areas around the lower back working better, so they can take some strain off your lower back. I'm also going to help you, because you sit at the desk all day, you're getting a little bit stiff. And so just doing a little bit of every so often work, just open that thoracic spine back out again. That's going to be helpful for your lower back to offset some of the way in which you use your body every day. Well, if they're going to do that, if that's their approach, that makes a lot of sense, because they're not overstepping what they can actually realistically do to help you. And they clearly understand their remit, their role in the recovery of you as an individual with lower back pain, right? If they're saying I can heal you, that's very questionable. That's very questionable. 1 year ago, 55 kilo Smith squats, 110 hack squats, and 95 kilo RDLs with straps. So 1 year ago. One thing I bear in mind, this is just from personal experience. I always remember when we had the COVID lockdown, so the 3 months where we didn't go to the gym. I went back into the gym and did like 60 kilos for the first time, and I was in bits for like a week. 60, which was not heavy at all, and I could definitely have done more. Just bear in mind, for those of you, especially those of you like who've got a background in training, as you get back into training using heavier and heavier weights, remember that, that DOMS that might well occur as a result of using a weight that on the surface of it you think isn't that strong, that can take you out a little bit for a couple of days, and that stiffness that can ensue after going back up to those kind of levels can be a little bit of a problem. So it's just worth bearing that in mind and being forewarned about the likelihood of those kind of ventures back into heavier weights. Even though the actual weight itself isn't that heavy on the grand scheme of things compared to what you've done in the past, it still can take you out a little bit in terms of that delayed onset muscle soreness and the stiffness that can develop in and around the hips, which can have an irritating effect on the lower back, right? If not kept in check well, with good care of self work, with good lower body stretching afterwards, with good work with the massage gun, etc., to optimize the recovery process. Just looking through some of the other comments over on TikTok. What else have we got here? JP says, hey Mike, do you think I should take a few extra days off work and let the flare-up settle? If you've got the flexibility to do that, yes, please, JP, have a look at the post that I did of the 2 pictures of me doing the hip hinge and you doing the hip hinge where I'm taking the weight off. That was a really, really important point to avoid these kind of errors in the future, because you can see the difference of the way in which we're both standing. I demonstrated it a minute ago. I should do it again just for now. When you're doing getting the bar off the rack, you're kind of stood almost leaning back like this and coming back off like that. Like that you can see the marked difference to when I'm doing it in the screenshot from me doing the live workout in phase 4, where I'm kind of over the thing and then we're braced. You can even see everything's tight because I'm wearing a t-shirt, and then I'm coming up and then I'm coming back. Like those little things make the world difference. Yeah, there we go. I don't mean work, I mean training. I'm at work now, and yes, definitely make sure I don't do that. Yeah. I think the problem is in that scenario is we're going to take some time off training, but fill the schedule with extra work. And extra work involves you doing this, coming down here, and all that kind of stuff. Which I think is, it's difficult for me to say that's necessarily the smartest move. I'd say, if we're going to have, it's difficult. That's a difficult one for me to say, yeah, you should do that. Yeah, I think it's too hard for me to just willy-nilly go and say, yeah, JP, have a couple of days off, because I know that those days are going to be used pushing ourselves in the schedule, doing all of the stuff that's involved in cleaning the cars and all that kind of stuff. And that's going to be significantly worse than doing the workouts. So it's that we've got to think about. So yeah, what I would say potentially might be if we were going to do a couple of days off, going to the gym, spending some extra time working on the hip mobility routine that's in the third core relief routine, where we're doing a little bit more robust lower body stretching, possibly even the flexibility library, which is a 40-minute hip mobility routine. It's a longer one because we have a good degree of limitation of mobility at the level of the hips on those hip hinges, and we've also built up a good level of strength on the hip hinges as per the videos, aside from the flare-up. So that's something to consider, but I think we've already touched on that in the chats in the members area. So we follow up with that. I'll keep an eye out for your comment, JP. What else have we got here? Limitless says, I posted a Facebook page about plateauing at the 40 kilo squat and holding that this week and next week just to continue. Yeah, I do think it's worthwhile. That 40 kilos has been like a real sticking point. 40 kilos with the hip hinge, I think, is a little bit more strenuous than 40 kilos with the squat. So I think just pausing for a moment wouldn't be a bad idea. Yes. And I'd say it would be better to just pause for a moment and bank that and then push on up to 45, 50 kilos. And see how you go after that forced plateau at 40 kilos. That I think would be better. And then push on to 45, 50 and see how we go through that process. And I'd also, just because I saw the comment about the Smith machine squats, leave Smith machine squats out. I know you're not doing those at the moment, Nirav, but I don't think those are that great. Theodore said, did you used to play rugby? Yes. Yes, I did. That was a while ago. Should you be worried if sciatic problems shift from side to side depending on my exercises? Not really. That's the symptoms. The one thing that you guys need to be mindful of, and I certainly want to be very careful when I say this because I don't want you to obsess over it, is you want to have a knowledge of what the emergency symptoms to look out for are when it comes to lower back injuries. You want to know about the saddle anesthesia, loss of bladder and bowel control, those kind of symptoms. Those are the kind of the emergency. You need to go and get that checked out right now, right? If things suddenly worsen, you're struggling going to the bathroom, you can't control yourself in that scenario, you need to go and get that checked out swiftly, right? But when we have symptoms swap a little bit from here to there, it often freaks people out, but you're going to have flare-ups along the way with lower back issues because you're living life every day. I mentioned, JP, we've got a mobile valeting company because you can see it on the thing, right? And we've obviously discussed that, we know that, but you guys are doing lots of different things every single day. If you had a bad leg, right? If you had a cast, for example, if we take that example with JP, right? If he had a broken or significantly sprained ankle, he'd just stick his ankle in a boot and crack on. Fair enough, right? But the ankle's protected in that scenario. We might slip a little bit and hurt the knee. that's a different story, right? If the floor's wet, but the ankle would be held out of the equation. Okay, and so that's the situation with the lower back. So we're going to be flaring it up as we go through the process. The question is, can we educate ourselves and improve our coordination and control as quickly as possible so the frequency with which we expose that lower back to unnecessary stress and strain is diminished significantly? That's the aim. That's why education is so important when it comes to lower back issues, because you can't avoid taking your back with you wherever you go and putting it under strain. So we want to try and be a bit more strategic. And JP, when you're doing the flexibility program, just keep in mind that lower back as you're doing it. One of the big things, when we're doing any longer stretches, which do become relevant later on, always be lazy. Always think about having a chair there to support you so you can be a bit lazy and lean on it while you're doing a hip flexor stretch, for example, right? Or if you're doing the hamstring stretch and you're doing a longer variation of hamstring, you've got something there to lean on while you're holding this hamstring stretch, right? Rather than just trying to float or doing this and just holding it for ages, that's just going to get you back tired and irritated, right? Unnecessarily so. So I talk about that in the flexibility stuff anyway. JP, if there's anything that you want to ask specifically about that, do a post in the members area and I'll clarify any bits there. But you want to set yourself up when you're doing your stretching, whether it's in the core relief work, guys, in the program, in that section of the program, you want to set yourself up so you can be lazy when you're doing stretching without compromising the lower back. Nirav, where is the hip mobility work for the hips library? I can't find that on the site. Also, when is the app going to be released? I've got a meeting with the developers next Tuesday. Wait, I forget what day it is today. No, it's tomorrow. It's tomorrow. So I've got a meeting with them tomorrow, actually, about that. So I'm hoping very soon, although I'm aware I've been saying that. We've run into a few little hiccups along the way, but it's almost there. With regards to that hip flexibility thing, I'll do a post in the members area and I'll get you a link because you might need, I'm just thinking of memory as to when you joined the program. If you joined after September the 1st, I think, we'll need to add it to your account. There's no charge, but we need to add it to your account. What else have we got here? JP says the 40-minute part 2 stretches. Will I need a bed or anything? I'd probably do it either in the bedroom or in the living room where you've got the sofa or something like that. Yes, most of it is on the massage bed, but you can use a sofa. A sofa works perfectly well. A sofa and like a chair can be like two really good bits of gear. Like for example, you might have like, if we use the examples here, I've got the bench here, right? I'll just put that down. So this is for a setup for stretching in a more back-friendly way. Right? And pretend this is a chair, right? So if I'm doing, say for example, I'm doing a couch stretch, I've got this here to support me so I can lean on this and I can push myself up and I can block myself. Obviously, you can see there what I'm doing, right? And I can block myself here so I can get into the position, I can readjust and then boom, and I can more easily maintain a little bit less strain on my lumbar spine while I'm doing this stretch. Or if I'm doing the hamstring stretch, not quite the right thing, but I mentioned earlier, you know, you want to have a couple of little light things around you. You don't have to buy any special gear, right? Just stuff around the house, okay? But make yourself comfortable when you're doing your stretching. You don't want to have to be exerting unnecessary energy trying to just hold yourself upright. Now, I hope you got that bit about the flexibility thing. What else have we got here? Bobby says, I've been told I have bilateral nerve entrapment on both sides of the L5. There's probably some kind of large circumferential disc bulge, I'd imagine there. My back has eased off, but it's in my right leg that we're noticing the symptoms. That's what Bobby's saying. You need to focus on stabilizing the lower back. That's exercises like the dead bug, the marching bridge, the squat, the hip hinges, those kind of things. You need to learn those movements like the squat, you know, apply them to your daily life. Leverage some care of self activities like the decompression, the contrast bathing, all of those things. No worries, JP. Leverage those to manage the excess inflammation around that disc down here so it can calm down, right? And then build back up strength and stability. And stop irritating it every day. Great. Thanks, Nirav. Lauren. When is it safe to begin exercises? I'm in the acute phase. I love this question. I'm in the acute phase now. I still have high pain and intense muscle guarding. Yesterday. Yesterday was the best time to start your exercises if you're in the acute phase. Why? Because you're still doing stuff in the acute phase. Lauren, did you get up out of bed in the morning? Lauren, did you get dressed this morning? Lauren, did you have breakfast downstairs, right? Did you go down the stairs? Have you been out the house? Have you been moving around the house? You've been doing stuff every single day, right? The first exercise, for example, in the program, well, actually, it's not even an exercise, right? The first exercise is standing against a wall. Can you align yourself vertically or not? Can you appreciate that? Or are you walking around the house like this? You know? The second exercise, lying on your bed. Learning about engaging the core. Okay, how do I do that? If you can't do both of those two things, how can you perform a squat? How can you do many things every single day if you can't do those two things? Because if you're not going to engage your core, then how are you getting out of bed in the morning? And if you're not doing a squat, how are you getting out of bed in the morning? So you start those things immediately. That doesn't mean you're doing them at a very high intensity. It doesn't mean you're doing them at a high intensity. But they do need to be done. That's how you build strength. That's how you get things to settle down faster, by stopping aggravating your lower back so frequently. And so we don't just leave it to happen on its own. We start the rehabilitation process. And if you're a little bit more sensitive, a little bit more, flare-upable, right, if that's a word, more easy to flare up right now because of this acuteness and this muscle guarding, etc., then leveraging tools like the contrast bathing, like the towel decompression, like the lower body stretching, those kind of relief strategies will be all the more helpful, while also engaging in the educational material. Because so much, it's so true, you don't know what you don't know when it comes to lower back issues. And if you don't feel like pushing yourself too much, you've done a bit of the strategy stuff, you've done a bit of you played around with the core engagement that I just demonstrated, you played around with the dead bug, you started playing around with that exercise, you've done a bit of the core relief work. Watch some videos on education, because that'll help you understand the situations better, and also it'll help you start to realize, there are 5 things I do every morning that are messing my back up. So maybe I should start with eliminating those as quickly as possible. As quickly as possible. Should move that on TikTok. There we go. Selena says, I'm really aching today, 6 days post-op. Is that normal? If you're 6 days post-op, please reach back out to your surgeon and just let them know. I would suggest if you've just had back surgery, I wouldn't be surprised if you are feeling a little bit sore. If I've had a workout, a particularly vigorous workout, certainly 2 or 3 or 4 days afterwards, I might still be feeling a little bit aching or significantly aching, right? And that's nothing like having back surgery. So you know, I don't say that to make light of it, but I do say that to say, look, if you've just had surgery, it's not unreasonable to suggest that you might be aching. But in that kind of time proximity to your surgery, reach back out to the surgical team and let them know. That's the first port of call in those sorts of time frames. Unfortunately, though, the guidance that you guys are left with, like Selena, if you're still on right now, did you drive home after your surgery? Did you get out of the hospital bed on your own? Did you walk to the car or the mode of transport to get home? And did you walk from there to your front door and into your house? Did you do any of those things? Let us know in the comments. I'll keep an eye out. Woozig, Woozig says, can you remind me what chair you have? Yeah, if you guys are in London, this is a plug. I have nothing to do with them, but we used to always walk past the shop. It's called something like Back in Action, I think it is. And they were in Marylebone. I think they've got one in a few other areas of the country, maybe in Bristol as well. But they sold lots of different chairs. And this is where we got this Hag chair from. It's called Hag Capisco or Hag Capisco. This is the cheapest model that they do. We are not affiliated with this company. We're not affiliated with this chair. We get no commissions or anything like that from these chairs. So I just want to be very clear about that. I think they're cool. I do think they're overpriced, especially like this one was, I think, 300 and something pounds, reduced from 500. You know, it's a bit much for what it is, if I'm honest. And the upholstered versions, which have a bit more cushioning, as well as one has a headrest up here, like they are like 13 to 1500 pounds. So, you know, but the reason I mentioned that company, because they don't make them, they just stock them, I believe. Well, they did it when we used to live there. Is that you can go in and you can actually get on the chair, you can sit on it, you can feel how comfortable it is, right? One of the advantages on these, providing it's okay in your office, is sitting like this is super comfy. If you've got a bad back, sitting like this feels so good. Right? And you can probably do this with a normal chair, but this is just these armrests here. I'm sorry, you guys, the contrast isn't as great on the green t-shirt, but like, this is so comfy. And if you're just there like this, it just takes the pressure off your back because you're just resting on it. It's very nice. Maybe not such a ladylike, you know, posture. Maybe not such a professional posture if you're in work, but if you're able to work from home, you know, I think crack on. You might find it quite comfortable. But it is a very fidgety chair, I think. I think if you're moving around a lot, it works well. The way in which I'm moving around, I think it's good. Others of you that are kind of doing more detailed work on the computers and you're sat, you know, needing to focus a little bit more, maybe you could do with a different kind of chair. It does also have the saddle to it. So it would be nice if it went a bit higher, but the saddle allows your legs to drop away like so, which helps you keep a more neutral spine. So you can play around with your positions. You can be a fidget. That's a really big one. Be a fidget when you're sitting down. Selena's come back and said, yes, all of those things apart from driving. She did all of those things. So Selena just had back surgery and she got out of the bed on her own. She walked to the car. She got in the car. She didn't drive, but she was driven, which means she was sat, maybe in the back, maybe in the front. Maybe there were bucket seats, maybe there weren't. Maybe the seat setup was optimized before she got in the car, but it probably wasn't. And then she got out of the car at the other side, maybe with a bit of assistance, maybe not. Like all of that was done after having back surgery, guys, right? And the surgeons know that's going to be done. So being fearful of you doing this is wrong. It's wrong, right? It really is. Really, Selena should then have some appropriate guidance on the neutral spine, on how to protect it, on how to move whilst maintaining neutral spine so she doesn't go inadvertently go and start putting extra strain through that particular area of the lower back that's just been operated on. But thank you for sharing, Selena. That's really helpful. For many others, I'm sure. Scott says, I've just had a good 2 weeks and then I'm having an almighty flare around my pelvis. Very, very painful. This is very normal because what happens often is when you're having a good few weeks, the motivation to do the exercises often drops down. The consistency with which we're doing the exercises drops down. I think I can see a motorbike maybe in that photo. So we think, yeah, do you know what? I'll take the motorbike out. I don't know if it is or not, but it looks like it might be in Scott's profile pic. We go, do you know what? I'm feeling okay. I'll take the motorbike out. What position am I in on that? What looks like a super bike? I'm over like that. You know? Maybe the weather hasn't been for it. It depends on where you are in the world, Scott. But we start doing other stuff and then we get a flare because, and this goes back to maybe the start of the conversation, the start of today's live session. It's not about how you feel, but you guys go and try and get help for back pain, for sciatic pain. So it makes sense to suggest that Well, of course, if you feel better, the pain's gone away, so there's not a problem, right? But that's not true. It's when the injury is recovered. How do you know the injury is recovered? Because you have gotten stronger, because you can demonstrate that on a squat and hip hinge. Having a look at what we've done in close proximity to this flare-up, like what were we doing when we had the flare-up? That's important information. It probably won't change anything, right? But it at least goes, yeah, maybe it was too soon to take the bike out for a spin, for example. Or it could have been something unlucky. It's like, yeah, actually, I slipped when I was going down the stairs carrying the toddler, because they pulled my hair. That could be an example. Jasmine has said she's getting IDD. Why don't they increase the pounds sometimes, even though I'm not sore after the session? I personally don't like just arbitrarily increasing the pounds, right? We typically use more conservative settings on the decompression table if you're using IDD. If you're getting the decompression, one example I do, so I do this with patients, and also when we get other chiros and osteos that come to the clinic to have a look at the table, and we do a bit of kind of tutorial-y type stuff with them. I go through this, if they're thinking about getting a decompression table. And I talk about this, right? If I gently squeeze the wrist here, I can create a little bit of decompression. So if I was to hold your hand, I could gently squeeze the wrist, and I can just decompress your wrist joint a little bit. Just a little bit of gentle force. They only decompress so much, and the same for the lower back. If I use more force, what happens is the person goes, oh, no, that doesn't feel nice, and they contract, they restrict, and then I can't get through the muscles. And so if you're getting the decompression occurring at the level of the spine while you're on the table with 45 pounds, let's say, you don't need more. All more does, and this is from experience of doing decompression for over 10 years, all more does is increase the likelihood that you are going to feel sore off when you get off the table. Now, sometimes when you're using the decompression and you unlock the table, this is specifically for the IDD machine, the spinal decompression machine, the big one that we've got behind that wall in the other room. Sometimes if the force is genuinely not enough, the table won't move. It won't unlock. They'll get a bit of stretching, but it won't actually unlock or unlock sufficiently. And so in that scenario, yes, we do need to increase the pulling force. But more is not equated to more healing when it comes to the IDD decompression. And I think your clinicians will probably agree with this and probably say something towards the same sort of thing. Fantastic, you don't feel sore afterwards. That's great. It's not a problem if you do, providing it's understandable and explainable, etc. But you don't just need to have more force on the decompression table. That's not a recipe for success. I would suggest just arbitrarily saying, oh, more force, more force. It's not going to speed up the healing or anything like that. Bobby has said, can leg length discrepancy be caused by herniated discs or cause herniated discs? No. Most people, myself included, my left foot is slightly larger than my right by almost half a size. My left leg is slightly longer by around about 5 mil. That's been measured accurately on X-ray imaging. Most people will have some discrepancy from one side to the other in their leg lengths. Whether it's negligible or not is another category. But most people that don't have a leg length difference will often stand in a way that results in a leg length difference. Standing on one hip, this kind of stuff, right? Changing the leg lengths. We very rarely stand like that to attention. It's perfectly reasonable. Now, 2 centimeters difference in one leg versus the other, I would very much question that if that was done in a physical examination. If Bobby's examination was done on a chiropractic bench or a physio bench and was not done standing with your feet together on an X-ray where they're measuring the top length of the femurs, then I would completely ignore that comment about 2 centimeters difference. It sounds like, now I have seen 2.5 centimeters difference in leg length measured, because I measured it on the X-rays. It was actually a friend of mine. But it's very uncommon to be that significant. And so that kind of number, it could be, right? But that's nothing to do with the herniated disc. That's literally your leg length. The bones are of different length to the tune of 2 centimeters. If that was actually the case, objectively speaking, which I would question. And in which case, yes, that's going to increase the asymmetrical strain through the disc. So, for example, left to right, your disc is going to be like that on the sacrum rather than square. But at the same time, we could make the case that if you spend a lot of time sitting every day, you completely negate the asymmetry in the legs. Additionally, you will probably habitually stand in a way that maybe levels the pelvis off, perhaps. You could do, right? So there's all those other sorts of things. I don't tend to read too much into leg length issues when someone doesn't have a baseline level of competence as a human being to do certain movements, because the leg length issue has been there since you were a teenager or since you'd finished growing, right? So that's something worth bearing in mind. Obviously, I don't know how old Bobby is or isn't, but just something worth bearing in mind. Best therapeutic movements for the SIJ issue. If you're pregnant, I would go and see an SIJ specialist or something like that, or a pregnancy specialist. But if you are not pregnant, your SIJ basically doesn't move. It moves by 1 or 2 degrees, which I think is beyond the scope of a clinician to actually perceive. And so I think really all the stuff about SIJs is I don't think you're necessarily doing what you say you're doing. If you can't fundamentally evaluate the mobility of the joint clinically, then you kind of, are you really interfacing with it? How do you know you're not just moving the hips and the lower back? Because clinicians cannot, with their hands, measure the movement of the SIJ outside of the pregnant lady, right? Where there's extra levels of laxity, et cetera, et cetera. And so I'm very, very skeptical when we start talking about SIJ issues as a primary issue. Can the SIJ be irritated with a lower back issue that's managed poorly? Yes, 100%. Can the SIJ be involved in the issue? But yes, but it's not going to be the causative factor. And you really can't do anything to your SIJ, right? Go and move your left SIJ. Yeah, we can make some statements that if we kind of get on, stand on one leg and we kind of go like this, it's like, okay, well, how much of that are you really moving the SIJ? And like realistically speaking, or other such movements where we kind of get on all fours, and we're kind of like dropping through the pelvis. How much of that is the SIJ or just the hip, right? Because again, this sacroiliac joint is going to move a very, very, very small amount. Now, can you move your left SIJ by 2 degrees to the left or to the right? Probably not, because I can't. I don't know how to do that. And I doubt that the clinician that you've got knows how to do that either with any degree of specificity. So it's important as well to understand that we can make these assumptions, make these claims, make these diagnoses, make these observations in imaging, and even measure some of these things. We've done some of these on the live sessions before, and wow, I'm overrunning like a big time. I think I'll wrap it up there. We can do these things, right? But we also need to have the wisdom to know whether or not we can actually interface and affect these things directly, or whether it's something that we can indirectly affect. And that's a really important thing to consider as well. Guys, I'm sorry I've overrun so much. I do hope that's been helpful for you guys. If you need any more support, check out, if you're over on TikTok, if you're over on Instagram, you can check out the link in the profile page. That takes you to the website. You've got the contact us form. You can join the program there as well to get help with your lower back issues. That's probably the best place to go. Those of you guys in the membership, we did send out an email yesterday on the Sunday email with 9 spaces for a virtual consultation. I think there's only 2 of those that remain. So if you're interested in those, I would have a look at the Sunday email ASAP, because there will not be any more after that, certainly not for a couple of months. So it's just something we've done. We explained in the Sunday email. So those of you that get it will know what I'm talking about. Those of you that don't, if you're interested, just send us a DM, but you'll have to do that pretty quickly. Other than that, guys, yes, if you're in the members area, need more help, more support, more guidance, please do post. We're there to help you all the time. If you're not in the program, you can always check out the link. It's backinshapeprogram.com/join. It's where you can learn a little bit more. Watch that handy video that gives you an insight. This is one of the things that we really want to do, is be as transparent as possible with you guys. You can check out that link. There's a video there that shows you guys inside the members area. It shows you guys inside the material, how we lay things out, how we structure the program. If you like it, you can sign up there too. And other than that, we'll be back in probably on Wednesday. I think Wednesday's the next live session. So have a great day, guys. Take care.